Good evening, everyone. With great pleasure, I, Dr. Mithilesh Nayak, on behalf of Inter Pharmaceutical Limited, welcome you all to this 12th episode of Endocrine Talk Show. And in today's session, we are having interesting discussion, cross-specialty discussion on various aspects of managing PCOS. And to moderate and chair today's session, we are having with us our post-director for the program, Dr. Chaudhary, who is guiding us from the beginning in conducting this endocrine talk show and has constantly provided valuable insight and expertise. With his guidance and constant support, we have successfully completed a year in this webinar series, and we look forward to another informative and engaging discussion on PCOS. So with this word, I hand over digital podium to Dr. Chaudhary sir and request him to introduce our panelists for today's program. Over to you, sir.
Very good evening to all our participants from across the country, and of course, a warm welcome to our panelists who actually make the program so interesting and useful and provide knowledge and also share their own experiences. So, this evening we shall talk about polycystic ovarian syndrome, which we know is possibly the commonest endocrine disorder that one sees in young women. And it really has a multi-faceted pathophysiology or pathogenesis. I don't think we can definitely say this is the cause for PCOS. There would be several factors, and the manifestations are different, maybe in different degrees in different individuals. And so to tackle this problem, but this, which is different manifestation, but which is common, we have this evening a very rich set of panelists from across the country. And so it's not just endocrinologists who see or treat polycystic ovarian syndrome. We have, therefore, not only got endocrinologists for you, we also got gynecologists, we've also got dermatologists. So amongst the endocrinologists, we are very happy and fortunate to have Professor Pramila Kalra, who heads the Department of Endocrinology at MS Ramaya Medical College at Bangalore. We also have amongst endocrinologists Dr. Usha Ayagiri, who is with is a consultant endocrinologist at the Apollo Clinic in Chennai. She had trained in Oxford. She was also a full-fledged consultant in endocrinology in the UK till he took the right decision, we feel, to come back home and come back to Chennai in 2014. And we are very happy to have with us gynecologist, Dr. Bashub Mukherjee. He also happens to be from Calcutta. He's a senior practicing consultant gynecologist in Salt Lake area in Kolkata. He was the vice president of FOXY in 2021-22 and current vice president at the Bengal Obs-Gynae Society. Welcome, Dr. Bashub Mukherjee. And we are also very happy to have Dr. Sharmila Patil, who is professor and head department of cosmetology at D.Y. Patil Hospital in Mumbai. So we have a rich panel. So I'll request all our participants to put in your questions in the chat box. And as usual, Dr. Mithilesh Nayak takes the trouble of sifting through those and passing them across to me. So while I'll check my chat box, I haven't seen any question yet. So essentially, we would like you to provide the questions that you would like to ask the panelists. And I would also in the same breath appeal to all of you to come up with your suggestions for any future topics that you would like to be discussed, including maybe certain topics that have already been discussed. If you like certain parts to be re-emphasized, we can always come back and visit those topics. So as we said, polycystic ovarian disease has multiple manifestations and multiple specialists who deal with it. Similarly, for management, we see different specialists. So can we have a quick understanding? I mean, we won't delve into the basics much. It is essentially a practical session to help our clinician colleagues in their daily practice. But still, what would the dermatologist, the gynecologist, and the endocrinologist think about the pathogenesis of PCOS? Just to see if there are differences in opinion or views. Maybe have the dermatologist first.
Good evening, all. Am I audible?
Yes.
Yeah. See, as a dermatologist, when we see PCOS, it's mainly in the young adult girls. And nowadays, with the late onset, also we are seeing adult acne. And it's mainly related with the hyperandrogenism, where androgen starts come secreted, and then which acts on the keratinocytes as well as sebocytes, and this increase in the sebum secretions. Finally, it leads to the lot of Cutibacterium acnes, and an inflammatory process starts with that. And along
Right.
with that, that's mainly a presentation to us with the PCOS. And then with this, we have seborrhea, acne, and hirsutism and
So
alopecia.
absolutely right. So for the dermatology, is essentially the excess androgen state. So is it any different for the gynecologist, Dr. Bashok Mukherjee? Bashok, please unmute yourself.
Thank you, Dr. Chaudhary. No, it's not different from us. So 1 in 10 women in the reproductive age group have polycystic ovary.
Bashok, your voice is trailing. I can't hear you. Whether it's okay. Right? Would you try to switch off your video and see? Okay, yeah. Once again. Sorry, we lost your voice.
Sorry, I'm back.
Yeah.
Yeah, sorry. I'm in Patna too. I'm for a conference here, so my internet connection is a little better than patchy, but I'm not sure when it conks out. So can you hear me? Am I audible now?
Yes. Now it's better.
So in gynecology, we do see polycystic ovary a fair amount in the adolescent population, and slightly more in the subfertile population. So the subfertile women who come to us, many of them present with polycystic ovary as one of the causes of subfertility, along with other issues. Adolescent health and adolescent PCOS is another spectrum and gamut of things which we see. And I think one aspect which we don't always highlight, which again I don't see here, is the mental health of polycystic ovary. And that is something which is really not much looked into. The obesity and the hyperandrogenism make teenage women, girls go mad. And that's something which I think we would like to focus at some point of time, Dr. Chaudhary, in this panel too. Thank you.
Right. So the hyperandrogenism and its consequences, I mean, because to you, they would present more with menstrual irregularity and, of course, subfertility. Right. Okay. And so maybe Pramila, so from an endocrinologist point of view, is it just about excess androgens?
Yeah. So good evening, everyone. And thanks, Dr. Shubhankar and Intas for inviting me for this talk show. It's really interesting. So when we talk about PCOS in our setup, as an endocrinologist, we see varied presentations. So one presentation is like they may go to the gynecologist with menstrual irregularities, or they may come directly to the endocrinologist with menstrual irregularity. That's one of the presentation. The other presentation is a combination of menstrual irregularity with weight gain or obesity. That's another way, with insulin resistance. Many of them may come with a pre-diabetes state, and they may come with more of insulin resistance features. That's another presentation. The third would be more with hirsutism as well, because a lot of patients with PCOS actually come to us with complaints of hirsutism. So that's another way they present to us. So they may present as either they will come with a diagnosis with menstrual irregularity, with obesity, with insulin resistance, with pre-diabetes. Some of them do come with diabetes and PCOS, and also they do come to us for infertility initially, because first they will come to us because they know that it is obesity, insulin resistance, infertility, and they know that, or they get a diagnosis of PCOS and they come to us. Sometimes we do directly get patients who come to us with an ultrasound diagnosis. So they'll come with one ultrasound, and then they are diagnosed as PCOS, and that comes from the ultrasound diagnosis, and they come to us for further evaluation. So that's another way. But just in the same sequence, I would just like to say that many a times these patients with PCOS who come to us may have features of androgen excess who may look like PCOS, and then obviously we are going to discuss it in the next few questions. But the other diagnoses also do come as a diagnosis of PCOS, where they do come to us with menstrual irregularity and they are diagnosed as PCOS on ultrasound, but they are picked up, and then there is some other diagnosis which is there, which we'll be discussing in due course.
Right. So thank you, Pramila. So I'll ask Dr. Usha two specific points. We have heard a number of times now, especially from Pramila, that obesity is part of it. So can we have PCOS without obesity? That's one specific question. The other is, again, Pramila mentioned that young women come with an ultrasound diagnosis of PCOS. So do you think that's a must? Do we need an ultrasound to make a diagnosis of PCOS? Please unmute yourself, Usha.
Yes, thank you very much, Dr. Shubhankar. So that's very interesting, because we do tend to associate PCOS with obesity, but we all know that there is a proportion of women with PCOS who are lean, and that about 10% of the women who present even with insulin resistance can be lean. So being lean by no means excludes either PCOS or obesity for me. And the second thing you've said, is an ultrasound enough?
Essential? Is it essential?
Is an ultrasound essential? Well, it depends on which criteria you would.
No, it depends on you. You are the treating physician for the patient. So what would you say?
Okay. So if I were to talk clinically, then I would say probably not, if everything else fits the picture. If everything else fits the picture. If you were talking academically, it of course depends on which criteria we're using for diagnosis.
Right.
But purely clinically, if I have enough to support a diagnosis of PCOS, then it's not an absolute essential. But equally, the converse of it, cysts on the ovary or ultrasound doesn't automatically make it PCOS, because there are a lot of women who come saying, I've been diagnosed with PCOS on the ultrasound. And then you have to explain to them that that's not actually a diagnosis, but one of the clinical features that we look at to solidify, if you will, consolidate the diagnosis. So
right. And yes. There are many patients, and especially for young girls, it's sometimes quite often the mothers whom I have been seeing for a few years would be asking me to, doctor, won't you do an ultrasound to check if the PCOS has corrected? So what do we do? Or should we? Could that be a baseline, that we need an ultrasound diagnosis initially, and then sort of demonstrate that the PCO morphology has changed? Is it essential? Is it important?
No, it is not essential from a medical point of view. However, it may be, and in fact, it could be misleading to the patients, because you may have a resolution of the clinical features without a resolution of the cysts. And again, I come back to this, that cysts on the ultrasound don't necessarily represent PCOS. So we need to make that an ultrasound, while it's helpful for the diagnosis, doesn't really either exclude or confirm the diagnosis on its own.
So that's a very clear message that we have got, and I'm sure all the panelists agree on this point. The gynecologists included. Yes?
Yeah, Dr. Chaudhary, just one point I would like to bring here. Yeah. So are we essentially saying, which I also tell my patients, once a PCOS, you're stamped a PCOS in a way for life. So what you have is symptoms, and those are the things which you essentially treat. But doing a sonography repeatedly to see whether the cysts are gone does not make sense unless you're doing it for another particular reason. And I think that this discussion, which Dr. Usha said, starts very early in the gynecology clinic, that cysts in ovary are not all the same. There are several reasons why we have cysts in the ovary, and a polycystic appearance just happens to be one of the many types.
Right. We already have a question in chat box, Dr. Agarwal. Symptomatic management or treating metabolic abnormality. I don't think it's clear enough. would Dr. Usha, would you like to take this question? Which approach is best to start with? Meaning, if a young girl comes with hirsutism, so is it enough just to treat the hirsutism part, or do you need to treat the underlying metabolic abnormality? I suppose that's what Dr. Agarwal wants to know. Please unmute yourself.
Sorry, I keep muting it because my husband is watching cricket in the background, being in Chennai.
Oh, yeah.
So, okay. Just an additional point, which again links to the answer to this question. When we talk about the pathogenesis of PCOS, we need to remember that PCOS is not solely a diagnosis of the young woman or a woman seeking fertility, and that there is a spectrum that can follow the woman through into her postmenopause. So, coming from that point to answer your question, what do I focus on? To a certain degree, yes, we need to take into consideration screening of the metabolic disorders, and I'm sure we'll discuss them during the course of this talk, and aggressively manage those metabolic disorders. The treatment of PCOS is very much dependent on the stage of the woman's life and her current requirements. For example, in an 18-year-old girl, it might be hirsutism, acne, or menstrual dysfunction. In a woman seeking fertility, it might be fertility related. In a woman maybe in her 40s, it may be metabolic related. So the treatment of PCOS is not exclusive to one or the other. It depends on the stage of a woman's life and the predominant symptoms that are troubling her at that particular point of time.
Right. And while we have more questions in our chat box, let me first go back to Dr. Pramila as to what is the essential sort of clinical examination that you would do in a girl who comes to you or young lady comes to you with suspicion of PCOS?
Yeah, this is very important because clinical examination is one of the prerequisites, because when they come with PCOS, as I said, they may come with varied problems.
And sorry, Pramila, and once again, we should remember our target audience is the physician community overall, not a specialist endocrinologist or who has all the time, possibly don't have so many patients maybe, but others have many patients to look after.
Yeah. So first of all, just to come to the typical, like if we are in a busy OPD and we have to see few features, one thing is there is a scoring called as the Ferryman-Galloway score, which is available online and anybody can see it online. It's on there are 9 areas which we grade from 0 to 4. So we have a total score of 36. So we can score with the Ferryman-Galloway score to see if it's more than 7 or 8, where we classify them as hirsutism. So if we have which is done, and the important thing is Ferryman-Galloway score is done for the areas, in the androgen dependent areas it is done. It is done for not for the villous hair. That also we have to be very clear. So if a person has come with coarse hairs which are in the androgen dependent areas, we do a scoring and we do it from 0 to 4. 4 is the maximum for each site. And if we see this hirsutism is present, that is one thing we can do. We also need to see clinically, like if a patient is looking virilized, obviously, then we have to think about that there is some other reason which is not mostly PCOS, that we are going to discuss, like late onset congenital adrenal hyperplasia, or sometimes adrenal tumors or ovarian tumors can present like that. So a typical thing is we have to do the hirsutism scoring. We have to see for features of insulin resistance, like acanthosis, skin tags, all these we can see. Basically, we can see the waist circumference of the patient if it is possible. If the nurse is around, that can be done. These are one basic things which are recommended. We can see the BMI of the patient. We can see the patient's overall phenotype, if there is any feature suggestive of Cushing's. Like sometimes they will look like a centripetal obesity. We'll see some typical features of Cushing's like stria. There are reddish pinkish stria which can be seen over the abdomen and other areas of the body which can be seen. So any features of any other secondary cause of Cushing's, which PCOS, which we are thinking of. And also we should see for virilization. If we are thinking that the patient is looking virilized, like breast atrophy and the masculinization features are there, and the hirsutism score is like very high, then such patients we should see for clitoromegaly also. So that is one which is a dedicated examination, but it has to be done with the patient's consent. with obviously the nurse around. So that is one more thing which we might have to do, not in all cases, but yes, we might have to do. So basically a Ferriman-Galloway scoring, that is a hirsutism scoring, features of insulin resistance, BMI of the patient, waist circumference would be a good thing to do, see for any features of Cushing, and galactoria we can see if we are suspecting, because there can be secondary causes like prolactin oversecretion, those can present. And just to add, rarely acromegaly can present like features of PCOS.
Right.
So if you're
Right.
feeling that your patient is looking like features of some acromegaly, it's a good idea to see that.
Right. And maybe even in a girl of 17 or 18, maybe check the blood pressure also as part of the overall insulin resistance problem. Right. But let me play the devil's advocate, Pramila. I am the patient and I am bothered with hair on my face. I don't mind whether there is hair on my legs or even maybe my chest or abdomen. So will you not treat me? Will you say you have a Ferriman-Galloway of 4, so you are not hirsute, so you go?
No. Yeah, that's a very important question. So what we have to understand that when we treat PCOS, it is more of patient-oriented treatment. There may be patients who may be not even bothered with a hirsutism score of 10, like hirsutism, and there may be patients who may be bothered with a score of 4 also. So what we have to see, first of all, obviously we have to first see that is there hyperandrogenemia also, what is the testosterone levels, and those blood tests we have to do. Also, if the patient is bothered with the hair, like if you're saying that only the facial hair and there is no hair anywhere else,
it
then
may
it is
may
like
not be there. Yeah,
may not be there. Yeah.
Yeah.
So definitely, if the patient is bothered with that score, we might have to treat, but the treatment may vary. So, like suppose it's only the like it's not hirsutism, and there are some small hairs which I see which are actually the vellus hair sometimes. So then there may be more of cosmetic treatment which will be done rather than actually the treatment with the hormones. So if I have a patient who is coming to you with the hirsutism score, like scoring of 7 or 8 or more, and the patient is bothered, then there are definite options. Like we know that we have hormone therapy, we have oral contraceptive options, we have options of spironolactone, we have options of finasteride. But before that, we have to counsel every patient of PCOS, no matter the patient is overweight or normal weight or obese or not, has to be counseled about lifestyle modification. That is the first and foremost thing I do. Then I will discuss the options of treatment for the hair with the patient. If I think this can be dealt with cosmetic treatment, I'll talk about cosmetic treatment and obviously keep my dermatologist into the team. And sometimes they might benefit with just the cosmetic treatment. But if the patient has hyperandrogenemia, patient has hirsutism, I definitely have to intervene not only with lifestyle, maybe with medications, which ranges from starting with the OCPs or the spironolactone, or with later 6 months later, if OCPs are not working solo, adding with spironolactone or finasteride. These all options have to be discussed.
Right.
This is how I'll go sequence wise.
Yeah. Right. So can I ask Dr. Basho Mukherjee, what are the investigations that you would normally ask for in such a suspected case?
Yeah, thank you, Dr. Chaudhary. So as we see as a gynecologist, again, they come to us with menstrual abnormalities and possibly hirsutes, acne. Would be those are the features which you look. As a hyperandrogenism, we always don't do a total testosterone. We have heard about a free androgen index being a very accurate way of trying to assess hyperandrogenism. But hyperandrogenism assessment is not a routine thing which all gynecologists do. But of course, they treat it once they see that it is cosmetically disturbing and it's enough to understand things. Yes, we do look at differentials, as Dr. Pramila and Dr. Usha both mentioned, that you look to have to see that depending on the extent, whether you need an endocrinology referral, whether you need to do other things, or you need to think about on the lines of things other than polycystic ovary, depending on the extent of the hyperandrogenism which is evident there. The other tests which you do, of course, sonography, if it's not done, the ideal thing would be a transvaginal one, but we know that most of the things, as if you have unmarried women, that may be touchy. Even a transrectal doesn't always give that information. So you have to do with the sonography lower abdomen with its limitations. And the other things we do as a hormonal assay, we sometimes do the FSH, LH, again, not always as a routine, but yes, again, as a routine, but the thyroid prolactin, of course, would be a test which you would normally do. About the metabolic part of it, the dyslipidemia and the other issues, which of course our endocrinology colleagues like yourselves do very frequently. We do it with time, but again, not sometimes in the first visit. But the first visit generally is a friendly visit because you don't scare her, because it will be a long time association with the patient. And so there are a lot of things to keep on discussing as the time goes by. So I think that's what the general thinking would be.
Right. So I have often seen, but not recently, maybe a few years back, glucose insulin ratio used to be a very popular investigation advised by the gynecologist. It's not so much used by endocrinologists, actually. So is it still used widely?
No, I think we moved down with that with the DIPSI recommendation of the 75 grams glucose and the 2-hour values, which we do in pregnancy. And I think some of that glucose challenge test which is now more prevalent than the fasting insulin. Those ratios are not done now.
Okay, so we now come down to our questions in the chat box. Dr. Singh, maybe Dr. Usha, you could take it. Is it wise to add metformin from a day when young women or girl diagnosed with PCOS, or any specific criteria to decide metformin therapy?
First thing to mention is that if you're going to consider adding metformin, please discuss it with your patient and document that it is an out-of-license indication. We do it commonly, but where we fail is to explain that it's an out-of-license indication. Second thing, if you are considering adding in metformin, you need to explain to the patient that this is safe for pregnancy, because these young women have irregular cycles. They sometimes may not even realize when they're pregnant, and we need to tell them that should they fall pregnant on it, it would be okay for mom and baby. So as for the question of do we add metformin, there is sometimes a misconception that metformin is added to promote weight loss. I think I have to emphasize that metformin at best gives you a couple of 2 to 2.5 kilos kind of weight loss and is considered a weight neutral drug. However, metformin does address the core physiological defect of insulin resistance in PCOS, and it's a drug that we use quite often. Even though we use it, it's not a substitute for lifestyle modification, and the single best intervention for metabolic health as well as some of the clinical symptoms, including menstrual irregularities in PCOS, is still lifestyle intervention and weight loss. Metformin as an adjunct to that is good, but please don't promote metformin either as a weight loss drug or as a fertility drug. Yes, it can improve ovulation because of improving insulin sensitivity. And if the woman doesn't want to get pregnant, we must make sure they're on adequate contraception. But please don't promote it as a weight loss drug, because I see too often saying we'll put you on metformin for weight loss.
So the other part of the question was, which specific criteria would lead you to decide metformin as a form of treatment?
That is more
from the metabolic aspect, from if you have IGT or frank diabetes, of course.
Yes, if there is a young woman who is dysglycemic in any way, shape or form, the choice becomes very easy.
Yeah, but beyond that, so would Dr. Mukherjee, would you add metformin to help ovulation induction, maybe with an ovulation inducing agent? Yeah. Do you think it works better?
Yeah. So Dr. Shubhankar, like in gynecology, there'll be two instances where we'll be thinking of metformin. One is in adolescent girls to regularize the periods, and one would be in subfertile women to encourage ovulation induction. So in the adolescent girl, like you would give her an option of hormonal and non-hormonal treatment, especially in a setting where she is overweight. And this would be one of the non-hormonal medication. If she does not have any birth control requirements, then this is something which may be offered to her for a limited period of time to see whether the periods get regular on metformin alone. That's one indication. The second, as you rightly said, in a subfertile woman, sometimes metformin alone with folic acid has shown to induce ovulation, and you would not need to give ovulogens like clomiphene citrate and letrozole, which would be our first line of fertility treatment generally. But sometimes, yes, as you rightly said, it's co-prescribed, where a metformin along with letrozole or clomiphene would be one of the combos which you would give for a polycystic ovary setting when you're trying to induce ovulation. And as Dr. Usha rightly said, that if she gets pregnant, we continue the metformin for some period of time, so usually 12 to 14 weeks, sometimes even longer.
And for Dr. Usha, Dr. Basu Mukherjee, both, we have our friend Dr. Sharma, who has actually added another point to the issue of prescribing metformin. So when we add metformin, many female complain that they were prescribed wrongly anti-diabetic medications, and quite often the pharmacy tells them, you've come with an anti-diabetic medication. Where have you got diabetes? So what's your experience? So do you forewarn them?
Hence my first point where I said, if you're prescribing metformin, please have the discussion and document it as an out-of-license indication for PCOS. And then we will not run up against the pharmacist telling them that
you've been wrongly prescribed something that you need.
Yes.
You did not need.
So I always document that discussion and I put it in writing on the prescription.
So, Dr. Choudhury, it used to be common around 10 years ago. This discussion would be more in the panels which we have in polycystic ovary. We do discuss this point about the pharmacist warning that it's a diabetic medicine. But as Dr. Usha said, that besides talking about off-license, you say one medicine for multiple uses, and the one the reach you're giving is very specific. And generally, people understand. You give them the warning before they go to the pharmacy, so they know that this is a medicine which is used variably, and this is for one particular indication, so that that stops the discussion there.
Right. We have not been utilizing the services of Dr. Sharmila so long. So now we come to you actually, because so many girls actually come because of hirsutism. So what would be your sort of line of treatment, A for acne and B for hirsutism? If you can quickly sort of outline.
Yes.
And then we'll also come to a few questions that our participants have raised.
Most likely the people, the patients who are referred to us with the PCOS are having a severe acne or they have a truncal acne. So as a dermatologist, our first drug of choice when we see a cystic lesions, we go for the isotretinoin.
And is that a local treatment or
no,
an
systemic,
oral systemic?
Systemic, oral isotretinoin. And along with that, we combine topical also, topical tretinoin, or we can combine it with the adapalene. Or we do have a now better combination like benzoyl peroxide with adapalene combinations that can be used in the night. And oral systemic isotretinoin will start the patient after screening them for the lipid profile.
What's the problem if I use it in the daytime? Why at night?
Normally they are photosensitizers, these retinoids. So if they use in the daytime, they will get a severe photosensitivity.
So they need to wash in the morning?
Yes, they can. They can start using it in the night first for 2 hours. And after 1 week, if they know that there's no redness or the excessive scaling, they can keep for the full night. And in the daytime, they can use a sunscreen. Now we do have a lot of sunscreen which can be used in acne-prone skin. So they should use a protect from sun rays.
Okay. So that's about acne. And so what about use of antibiotics? So I've seen prescriptions 2 days in a week or 4 days in a month antibiotic.
Yes.
For acne.
Systemic antibiotics, we normally feel nowadays most of the antibiotics the patients are resistant, but still we do have use of a capsule doxycycline, tetracycline group of drugs, which we give for 2 weeks. If there's a difference, then we can continue for 6 to 12 weeks, and then maybe we can switch over to the retinoids if required. But overall, the role of antibiotics is reducing because of the resistance which people are getting.
Right. And so quickly, let me ask Pramila. So a patient on retinoic acid or whatever isotretinoin that's been prescribed by the dermatologist, are there any metabolic concerns to the use of this medication?
Yeah, definitely. So whenever these patients are prescribed, we do monitor their lipid profile, and obviously they have to be given the advice for the contraception. And from our metabolic concern is the hypertriglyceridemia and the lipid profile, which we definitely need to monitor. So what happens that what we have seen is many a times these PCOS patients have dyslipidemia. So whenever a PCOS patient who comes to me, most of the time whenever dermatologist is initiating, they do the lipid profile at the baseline and send to us initially only. But and they are PCOS, we always get a consult most of the times, but sometimes we do see patients who already have hypertriglyceridemia, they have problems, and then they are started. So in such cases, we have to monitor and we have to follow them up. And the most important thing for treating is again lifestyle modification. So we again come back to the first thing that lifestyle modification we have to monitor, and in case the triglycerides are going very high, then we have to discuss with the dermatologist. Either we have to add the fibrates for a short period if it is mandatory, because sometimes the acne is so much and disfiguring, they have to give the treatment and continue, then we have to treat that. If lifestyle and diet is not working, in case it is working, then it is fine. If it's not working, then we add for a short period and continue with the treatment, because that has to be given, and add our own hormone therapy accordingly.
Right. Pramila, once again, very naively, can I ask you as a patient, so I've got hirsutism, significant hirsutism, and you advise me lifestyle. So my question will be, so doc, I'll follow that. Can you assure me that the hirsutism will go without any treatment, without any medical treatment?
Yeah, so the answer is that only lifestyle modification itself may not bring down the severe hirsutism totally.
Or unlikely to. In most of the cases, they won't possibly.
Yes.
That we have to be aware of.
Yeah. So what we have to tell the patient is there are different options. When they have severe hirsutism, we tell them that only lifestyle alone will not be totally taking care of that. So we have to have hormone options, which we give them the hormone options of oral contraceptives in such cases. Because for severe hirsutism, that is the recommendation.
Let's first hear from our dermatologist colleague their options for treating hirsutism. Yes, Dr. Sharmila.
Normally, here I would say that we get the patients who are already treated by the endocrinologist who has hirsutism, and then or sometimes
you don't like those patients, those who have been seen by the endocrinologist.
No, in fact, then we are very safe that they have treated and now they want to stop the hormonal therapy and they are only worried about the hair growth.
Right.
So when they are worried about the hair growth, our best option is the laser hair treatment, where we do use diode laser or long pulse Nd:ARC laser. And these are one of the best technology which are useful to treat the hirsutism. Our only suggestion is requirement is that patient should have a good terminal hair, because if we do the laser on the softer hair, the result will not be good. So that's the only way I would suggest that lasers are the options to treat hirsutism, irrespective of whether you want to continue your hormonal or not. And we do modify the treatments.
Sir, your voice is trailing, Dr. Sharmila. Can't hear you. Can others hear Dr. Sharmila?
No.
No. Okay.
Can't hear her.
Hope that gets rectified.
May I just mention one thing?
Yes.
So I think the other thing to counsel patients right from the beginning is, except for laser, none of these are permanent solutions. They slow down or thin the hair growth, but if the patients expect that they'll never need to remove or use any other measures, then we do need to set the expectations right early on, I think.
Right. So Dr. Sharmila, we couldn't hear the last part of what you said. Could you quickly repeat? No, there's no issues. I mean, these are high-tech issues that we have to face these days. Yeah.
See, normally for the hair removal, if a patient has got idiopathic or the family has a trend of thicker hair, then we do suggest them you should take a laser once in a 21 days to 45 days. And on an average, a patient requires 6 to 8 settings to get a good response. And then yearly, maybe 2 or 3 settings as a maintenance will be required to take it.
So that part also, I think we need to discuss that it's not just one time going and getting a laser done will not do the job. So even one course sort of would be 6 sittings, as you said, which will be spread across.
Maybe a year, depending on the growth. If the growth is very faster, some people require they get the growth even every 5 days. So such cases, we do it in the initial period once in a 10 days, and then you can increase the duration between the settings.
Right. Here, my concern comes that unless you have decreased the level of androgens, will your laser give you lasting value? So
most
do we
of the
need
time
to also treat the hormone levels?
Yes. So if the patient has the hair growth, they are already investigated by the endocrinologist, or even we do investigate the people. So if they are investigated, then only because see, most of the people are concerned with the look, the disturbances, or the quality of life affection. So in spite of that, we have to combinedly together treat that as a multidisciplinary, and that is the best way to approach the case.
Okay, so before I come down to the questions in the chat box, my question is, what about local treatment for hirsutism? I mean, apart from laser, medical, eflornithine, does it have any role?
We have felt that patients are not ready to use, and it is not really very effective. So,
Okay,
and when we have a better option of doing just laser, it works very well. And
right.
sometimes we start spironolactone, so that also can help. But we leave it to the endocrine. We don't try to interfere with the hormonal.
Okay, okay. So there are questions from Dr. Kothari. How effective is laser treatment for hirsutism not responding to medications? So would that be the indication where oral contraceptive pill or whatever spironolactone maybe the gynecologist or the endocrinologist has used, but still there has not been satisfactory improvement? Is that the indication, special indication for laser?
The best indication for the laser is that patient should have a thick black terminal hair. Then whether his reports are normal or not, the patient is going to respond.
Okay.
They become softer and there is a reduction.
Right. And any specific counseling points while referring for laser treatment? So what should we advise?
Most important, they should not have any photosensitivity, because they are the absolute contraindication. And the patient has to understand that this is a hair reduction, not the permanent destruction. And they have to have a maintenance therapy which is required for them.
Right.
So
That's
these are the
also
three
so
most
very
important.
Right. Good. Thank you. So now we come back maybe to Dr. Usha. So what is the medical treatment? What would the endocrinologist, how would they approach the hirsutism part of it? The dermatologist clearly has the laser treatment with them. What about us endocrinologists?
So, sorry. I think for us, it's primarily lifestyle management and oral contraceptive pill for reduction, because what we're trying to do is reduce the hyperandrogenism effectively. To a certain degree, reducing the obesity improves the insulin sensitivity, which reduces it. But lifestyle alone is not that effective, as effective for hirsutism as it is, for example, say for regulating the menstrual cycles. So quite frequently, we need an additional measure. Here again, we need to be very careful, because when we prescribe the contraceptive pill, this is the prescription that the pharmacist is likely to say, why are you on a contraceptive pill? And we need to counsel the patients and document once again that we are prescribing this specifically for regulation of cycles and hirsutism in this patient. I do use eflornithine quite frequently, especially if it's just facial hirsutism, with the clear explanation that it will slow down the hair growth and maybe make removal less frequent, but not as a ablation kind of therapy. Yeah. If these two don't work, then I move on, as Dr. Pramila was saying earlier, to anti-androgens, either spironolactone or finasteride. But I would prefer to move on to these in a girl who's already on contraception, because a pregnancy on any of these agents would be fairly catastrophic for both the patient and the doctor. And therefore, counseling to avoid a pregnancy on these extremely teratogenic virilizing drugs is important when you move on to this. Beyond this, I'll have to go back to the dermatologist and get their help for further management.
Right. No, but there's another issue. There are so many different oral contraceptive combinations. So is there any preference? And I'll ask the same to Dr. Bashub Mukherjee. Maybe Bashub, what is your view? Different progestins, different estrogen concentration. Yeah, so some of the progestins are anti-androgen, some are pro-androgenic, some are neutral. So shouldn't this matter?
Yeah, it will matter. It will matter in two cases. One is when you're regularizing cycles, and one is when you're bringing down the hirsutism and acne. So regularizing cycles, if it's because we know PCO is an estrogen predominant or estrogen excess environment there, you would like to give progestogens in some particular way to regularize cycles. Medroxyprogesterone acetate and norethistron come to the mind. But norethistron, we don't usually use. Medroxyprogesterone acetate is a much softer progestin in that way if you're using progestogen alone to regularize the cycles. But most often, as everybody has mentioned, we understand that combined oral contraceptives have effects beyond cycle regulation, where that is what it does help in decreasing the metabolic factors and the effects of the polycystic ovary. So cyproterone comes to the mind, where it's one of the strongest anti-androgens which is there available. Drosperinone comes as a distant second. So cyproterone would be the choice when it is more of a hirsute and a hyperandrogenic case. Drosperinone would be more of a choice when it's weight reduction and when it's an overweight woman there. And so it would be from 3 to 6 cycles. And as I think everybody has mentioned, it's so important to say realistic expectations. Expect nothing in the first 3 months. In 6 months, you may have some change. You take photographs and then compare it, not month after month, but 6 months.
Right. About cyproterone, my personal view is the anti-androgenic effect of cyproterone will be seen possibly when you're using 100 milligrams of cyproterone. However, the amount that's available in the combination pills are what? 2 milligrams or
yes,
what is it?
It's
2 milligrams. So does it actually provide a significant advantage is my question. I don't know. I mean, it's been used profitably by so many people, but that's my endocrinologist take on this matter.
We have seen in clinical practice, after 6 months, we have seen remarkable change with cyproterone more than any other oral contraceptive drug. Again,
Bashar. Yeah.
Everything has some of an effect, but this has the most profound, which we have seen. Combining it with anti-androgens like spironolactone or finasteride, we also do it from time to time. So it's not that we don't do it. We do it not fairly liberally, again, depending on the extent, depending on where we stand. Thank you.
Right. So we have more questions. Yeah, there's a quick one. Maybe Pramila, Dr. Akash Sharma wants to know, is PCOS hereditary? And I, in all these programs, I'm informed by the organizers from time to time as to how many people actually have registered and logged in. And I'm happy to tell you that people are so eager to listen to all of you that there are almost 100 doctors who have logged in from different parts of the country at this point of time. So Pramila, so the question is to you.
It is. This is a very good question because actually we have also done a study where even we tried to see the relatives of PCOS, the sisters and the mothers, to see if they also have, and that is one. But when we talk about genetics in PCOS, yes, there are genome-wide association studies which have been done, and total of around 19 loci for PCOS have been studied and found out. And there are many genes like FSHR gene, there is INS gene, there is VNTR, there is one new gene that is a Dendia. So these are the different types of genes which have been discovered. If a person has a mother or a sister with PCOS, there is a 30 to 50% risk of PCOS coming in the patient. And also we know that hyperandrogenism as well as insulin resistance are also genetically determined. So there is a definite genetic association of PCOS.
Right, and it could well be in the family, right?
Yes.
And there's one more question, Dr. Jain, who has asked a difficult question. OC pills are not suitable for many girls. Which alternative modalities are recommended in such situations? Dr. Basho Mukherjee.
Yeah, just one point on the genetic thing. This is the statement from our fertility doyen, Dr. B.N. Chakravarti. He used to say the word genetically predisposed, environmentally modified disease. That's what the terminology he used for a polycystic ovary. About OCPs, yes, that's a very important, pertinent point. People are touchy about using combined oral contraceptives for 13-year, 12-year, 14-year-old girls, which often present with polycystic ovary syndrome. In that case, as I said initially, you would need some sort of a cycle regulation. where medroxyprogesterone acetate would be one of your different choices. Also, metformin also would be, I think, as many people mean, we can try it, but again, at 13, 14, and 12, I think that is the touchy age where we really are a little hesitant to use many things. After 16 and 18, people are generally much more comfortable. But I would like to hear the opinion of your panelists and yourself. 12, 13, 14, polycystic ovary, overweight, obese with irregular periods. Would just a cycle regulation do, or do we need to do more besides, of course, lifestyle modification in a very big way at that point?
First of all, the diagnosis itself becomes a little bit more difficult in those early years because even normally you could have some irregularity in cycles in the first 1 or 2 years.
Yeah.
And also ovarian morphology and ultrasound may not be a reliable indicator. So I think all across you would be pushed to write drugs in a girl at 13 or 14 years. We would more like to re-emphasize the importance of lifestyle. And then still, if there is no significant improvement, then possibly would be forced to advise some medications.
And just if I can add a point about
yes.
OCPs, because like in South, what is the thing is, like in Karnataka state, we see a lot of CVT. So there is a huge proportion of CVT, and it is much more than what we see in North India. I worked in North India and I know that we used to hardly see CVTs. But in South India,
what is CVT, please?
That cortical venous thrombosis, these are like secondary to the OCP use. Right, so this is a very, very common thing which we are seeing here. So sometimes, as the question has been also asked by the audience, many a times we do get a family history of CVT, and we get patients who had a previous CVT. That is definitely a contraindication if they themselves had. But even if there is a family history, we have to be very cautious, and we have to evaluate those patients for the protein C and other factors, because they can be predisposed. So in such cases, sometimes when we are a little bit skeptical, we might not be able to give OCPs, even if we want to give them for hirsutism. And those are the situations where even we go with lifestyle and metformin, or maybe finasteride, and not with the OCPs, because that is another group which we see in our city, in our part of the country. So that's one thing also.
Right. So for Dr. Usha, there are a couple of questions. One is Dr. Yadav asking any role of prebiotics or probiotics in PCOS. Don't laugh. These are real
No,
questions.
I was waiting for this question. That's why I'm I'm waiting for this inositol. I'm waiting for the inositol as well. I always wait for this in the PCOS. So I'm not laughing at the question. I'm laughing that finally it has arrived. One word answer, no. The evidence is extremely slim for all of these. The evidence on gut health and several metabolic disorders is emerging, but there is by no means enough to say that modulating the gut health or modifying it with whatever biotics makes any difference to the outcomes in PCOS.
Right. Yeah. So the other question, I suppose, from Dr. Yadav only is your experience or maybe your views on use of other anti-diabetic medications like pioglitazone, GLP-1 receptor analogs, SGLT2 inhibitors in treatment of PCOS.
Okay, where I said metformin is out of license, these go beyond even out of license and commonly accepted by peer consensus kind of medicines, number one. Number two, we know pioglitazone is an insulin sensitizer, but in the side effects, people gain weight on it, and you certainly don't want weight gain. So the third and fourth SGLT2 inhibitors and GLP-1 receptor agonists and SGLT2 inhibitors may improve outcomes based on their weight loss, but only if you're using them in the context of concurrent dysglycemia diabetes, not on their own without diabetes. Of course, we are going to be getting drugs that are going to be solely licensed for weight management in the near future. That might be a different scenario. But at present, none of these drugs have a sole license for weight management with or without PCOS. And we cannot the use of any of these.
So that's a clear message. So these are not yet used for PCOS management per se. So Dr. Pramila, can we, this is Dr. Gupta asking, can we expect any metabolic abnormality in PCOS offspring?
Yes, definitely. There are studies in not only PCOS relatives, brothers, sisters, and offsprings as well. So, like I showed you that, like I told you that if a mother has PCOS, the child has or the 30 to 50% chance of inheriting it. The similar thing that is the offspring. So it is definitely there. So if the mother has PCOS, the child chances of getting PCOS is 30%. If both the parents are diabetic, the child chances of getting PCOS are much higher as compared to if one parent is a diabetic, no matter if the mother doesn't have a PCOS. Even premature baldness in the father is a concurrent risk factor for a PCOS in the family or in the offspring. So even that is a risk factor. So diabetes in the family, insulin resistance, or PCOS in the mother all confers a risk. Even premature baldness in the father itself is one of the risk factor. So these are all the risk factors, and
Thank you.
dyslipidemia as well.
Right. So we are sort of coming towards the end of our allotted 1 hour. So can we ask each one of you as to what the long-term concerns in a patient with PCOS? We start with Dr. Bashar Mukherjee.
Yeah, so the long-term concerns for us as a gynecologist after the subfertility stage is over, so you would be mainly the metabolic effects, and that's the time when they'll be seeing more of you and less of us. So it will be endocrinology handover, and by that time that you would be managing more of the dyslipidemia and the other issues which you would be facing at that time. So that would be the long term. Yes, we do talk about cardiovascular risk. We just talk about coronary artery disease, and we just do talk about other things of polycystic ovary in the long run. But yes,
Right.
lifestyle modification then scores everywhere there.
Dr. Bashar Mukherjee, you would be managing women with endometrial carcinoma. So would you think in the ones that you treated that they may have had PCOS in the past? Because that's what we say, that PCOS as a long-term complication, you are more liable to have endometrial hyperplasia and subsequently carcinoma.
Yeah. So endometrial hyperplasia and carcinoma, one of the logical thinking is that the more the estrogen in a lifetime, the more is the chance of her developing endometrial hyperplasia and carcinoma. So that includes early menarche, nullipara, less breastfeeding, etc., less use of oral contraceptives, and polycystic ovary, where she's got irregular, prolonged cycles which are not regulated over months and years. So if you have periods which are coming in 2 months and 3 months, a lot of people may ask you, so what, doctor? And then you have to say, so what? So this is what may happen in the long run. So I think that's something which needs addressing, and we do take care of that. And when we discuss this, does come up that why do you want to regularize periods, or how frequent do you want to have periods? We usually tell them 9 to 10 cycles in a year is fine. You don't need to have it every month, but at the same time, you can't go 2-3 months without having periods and say it's fine, I'm happy. So that may not be the case.
Right. Quick ones from the endocrinologist, maybe Dr. Usha, and then Dr. Pramila, as to your long-term concerns, cardiovascular health or
long term. As Dr. Mukherjee has mentioned, we do think about the entire metabolic health. So dysglycemia, dyslipidemia, cardiovascular health, the hypertension, and if please correct me if I'm mistaken, Dr. Mukherjee, but I think for endometrial health, I think 4 cycles in a year, I believe the literature suggests are enough to decrease the risk of endometrial carcinoma in the longer term. So, but
I thought it was more than 7 to 8 cycles a year. Not 4 was a little less. So
Every
I think
3 months is, yeah.
I think
7 is what we conventionally remember. Minimum 7 in a year.
7 in a year.
Yeah. And Pramila, anything new to add to this?
I think dyslipidemia, diabetes, GDM in pregnancy, cardiovascular health, metabolic syndrome as a whole has to be monitored. Weight management, that is the most important.
Right. Yeah. And would there be anything to add from the dermatologist side?
Only I would like to say that acne is now been identified with the interleukin-1, and so various inflammatory disorders like hidradenitis suppurativa and all could be on the rise. So we have to observe for that.
Okay. Right.
Just
Good.
one point, Dr. Chaudhary, I'd like to add. This is about in polycystic ovary. There was one point of time in subfertile women where we used to do laparoscopic ovarian drilling, and that's an intervention which is now I won't say obsolete, but is much of as a second line after the use of gonadotropins if it doesn't work in a subfertile woman. So laparoscopic ovarian drilling, which was once upon a time, maybe 5-10 years ago, a very common intervention in a subfertile population by endoscopy surgeons, has come down reasonably over the last few years, and there's enough of evidence to suggest it is not required in most of the cases.
Right. So I think we had a good overall discussion in this multifaceted problem of polycystic ovarian syndrome, where obesity is commonly associated, but it's not essential that one needs to be obese to have this condition. Insulin resistance is quite often there, but once again, possibly one does not need to measure for or look for insulin resistance to offer treatment. Most of it is fairly well treatable symptomatically. However, we need to be aware of the help that we shall need from our colleagues in other disciplines. So we have most prominently dermatologists and gynecologists are the ones who are common colleagues in this field of management. And overall, I think something that we need to make them aware, because quite often patients and their parents would often hope that you provide some medicine and my girl gets better in 3 months. So that is not to be expected, that we have to mention and inform them from the very beginning. And quite often treatment has to be quite long drawn for several years at least. However, at the same time, my personal observation at least has been for most diseases, we say that as time goes by, things tend to get worse. But for polycystic ovarian syndrome, my theory and my observation is at least the menstrual irregularity tends to improve over time. Though, of course, if the girl continues to go on gaining weight, then in the short term, she will not improve. But because eventually, if you have significant insulin resistance and eventually the beta cell starts failing, when the insulin level starts dropping, some of the features would tend to improve, but of course will be replaced by other problems like diabetes, dyslipidemia, and all that. But the initial manifestations can actually get better over a period of time. That's my observation. However, I think we had a wonderful discussion, and I must thank our audience for putting in interesting questions and stimulating a good discussion so that we could all eventually take back home learning points and help our patients better in our daily quest. So it's back to INTAS Zenith Division, Mr. Amit Arora, for the concluding comments.
Yeah, good evening. Thank you very much, Professor Shubhankar, for helping us create such a unique forum tonight. Our endeavor as an organization is basically to bring endocrinology and such sensitive topic closer to the physician to understand and treat their patients well. We don't have any products in this area, yet we continue to do these programs, and we are continuously doing such programs since COVID started. And I hope all the physicians who have joined in today have got the information they are looking forward for from such a program. So thank you very much, Professor Shubhankar, for helping us out and creating this forum. I would like to thank our panelists tonight, Professor Pramila Kalra, for joining in today, Dr. Usha Ayagri, Professor Sharmila, and Dr. Basab Mukherjee for sparing their valuable time on this platform and making this program successful. we had more than 1,000 logins tonight again. So it's sort of a record. I always mention that whenever we do these programs, there are more than 1,000 logins. And I must thank all the delegates who have spared their time on this weekend and joined in for this session. Thank you very much once again from
Thank you.
Intas. And
Very good night,
to
all of you.
We look forward to yet another session, maybe in the month of May. So I would look forward from Dr. Shubhankar for another program. Thank you very much once again.
Thank you.
Good night to all of
Good
you.
night.
Thank you.
Thank you and good night. Bye-bye.
Thank you. Thank you.
Good night,
ma'am.
everyone.
Bye-bye.
Bye.
Good night.